Hi guys, I'm Aaron, a provisional anaesthetic fellow currently working in Gibraltar. The idea behind this podcast is to present some common ECG findings that have important anaesthetic implications and are therefore often used in the Viva. Then we'll have you interpret them and then have some follow-up questions. Some of the questions are more broad than what would be used in the Viva, but that is intentional so more topics can be covered in a short time. There's also some crisis management questions. The reason for doing this is that often the investigation interpretation which catches candidates out in the Viva. Like in the last podcast, I would encourage you to pause the video so you can give your own answers. We have a 66-year-old male at pre-assessment clinic for a laparoscopic hemicolectomy for a colon tumour. He has a history of ischemic heart disease with an anterior MI 2 years ago with one left anterior descending drug-eluting stent inserted. In terms of cardiac symptoms, he has 3 syncopial episodes since that time at rest. He has no angina and is able to walk 2 flights of stairs comfortably. Please interpret this ECG. Pause now for your own answer. Like the previous podcast, this is my approach to looking at an investigation. And remember, you can always fall back on your structured method of rate, rhythm, axis, etc. if you don't see anything obvious. In this patient with a previous MI and history of syncope, I'm particularly interested in conductor box or bradycardia that may have been caused by the previous MI. ECG is sinus bradycardia with a rate of approximately 50 beats per minute. The most obvious abnormality is a right bundle branch block. He also has a first degree heart block. This history I look for axis deviation. He has left axis deviation which indicates left anterior fascicular block. These findings together indicate impending trifascicular block. I don't see any significant Q waves or other signs of previous damage from his MI. For this patient, I'm concerned he's having intermittent complete heart block with trifascicular block, and I want to refer to cardiology to consider a pacemaker prior to surgery. Would you like me to look at the ECG in any further detail? For follow-up questions, is a permanent pacemaker indicated in this patient prior to surgery? What are the indications for permanent pacemaker or prophylactic transvenous pacing in heart blocks prior to surgery? If surgery is too urgent for insertion of permanent pacemaker, how would you conduct the anaesthetic to reduce the risk? Pause now for your own answers. In this patient, a permanent pacemaker is probably indicated as the patient has unexplained syncope, so is symptomatic. I will refer to cardiology for this. Pacemakers are only indicated in impending trifascicular block if there is syncope associated or if there is second-degree AV block type 2 or higher. Asymptomatic bifascicular block plus first-degree AV block is not an indication. These are the indications to remember to consider inserting permanent pacemaker or prophylactic transvenous pacing prior to surgery. Third-degree heart block, symptomatic second-degree heart block, usually type 2, symptomatic impending trifascicular block. This always needs to be weighted on the urgency of the procedure. I would use my structure for arrhythmias of prevention, reduction of causes under anaesthesia, detection and preparation for management if it occurs. For an urgent case, I would discuss with cardiology the availability and risk versus benefit of inserting transvenous pacing wires for a temporary pacemaker for treatment of heart block if it occurs. To reduce the risk of occurrence under anaesthesia, I would discuss with the surgeon whether open or laparoscopic and ask the surgeon to increase gas pressure slowly if laparoscopic. I would use midazolam pre-med if anxious, and I would prevent increased vagal stimulation by obtunding response to laryngoscopy with fentanyl and pain by inserting an epidural if not contraindicated or by using a remifentanil infusion, being mindful that this can worsen a bradycardia. For detection, I would use continuous ECG monitoring in an arterial line. For management, if it occurs, I would have atropine ready, noting it may be ineffective, and 1 in 100,000 adrenaline drawn up to 10 to 50 mic boluses if required. I would have a pacing defibrillator in the room with pads on, and if transvenous pacing wires are inserted, I'd have them connected and know how to use the temporary pacemaker. I'd arrange appropriate post-op care in HG with continuous cardiac monitoring. You are carrying out an emergency laparotomy for bowel perforation on the same patient, which you elected to do without transvenous pacing wires as the patient is septic and there's no one in your regional hospital that can perform them. Midway through the open surgery, you see this on the monitoring screen. What do you do? The patient is hypertensive and bradycardic with a rhythm strip that shows complete heart block. I would declare the situation to the room, ask the surgeon to stop, turn FO2 to 100%, give atropine and 20 mics of adrenaline. If this did not improve the situation, I press the emergency bell for help. I would give a further bolus of 50 mics of adrenaline, and if this didn't help, I would start transcutaneous pacing. Right, so that's the end of the Viva part. This picture of the conduction system reminds us of how conduction blocks occur. In impending trifascicular block, there is a blockage of the right bundle, giving a right bundle branch block, blockage most commonly of the anterior fascicle, causing left axis deviation, or blockage of the posterior fascicle, giving right axis deviation. The prolonged PR means the remaining fascicle is failing and predisposes to trifascicular block, which is a cause of complete heart block, which causes the symptoms of syncope. Now on to more ECG interpretation. We have a 65-year-old man in pre-assessment bay with acute appendicitis. He has a history of a previous inferior MI and is feeling faint after IV insertion, so ECG was taken. Please interpret this ECG. Pause now for your own answer. I'm looking for conduction blocks and bradycardia in this patient. The abnormality is complete heart block with a ventricular rate of 27 and a sinus rate of 60 with no AV association. This is a slow ventricular escape rhythm, and the patient is symptomatic, so requires urgent resuscitation. Would you like me to look at the ECG in more detail? Now we have a 75-year-old female in PACU after laparotomy for bowel obstruction, and she's experiencing chest pain. She has a history of ischemic heart disease that is not amenable to surgery or stenting. Please interpret this ECG. Pause now for your own answer. In this ECG, I'm looking for ischemia. The abnormality is large ST elevation in the inferior leads, and the patient is bradycardic with a ventricular rate of 38. There's AV dissociation with an atrial rate of 85. So this is a large inferior STEMI causing a complete heart block. The patient needs urgent treatment of the STEMI and increased heart rate to better perfuse the heart. The treatment may be complicated by the recent surgery. Would you like me to look at the ECG in more detail? So, for summary of complete heart blocks, there is a dissociation between the atria and ventricles, which is the key to diagnosis. Usually a pacemaker or transvenous pacing wire is needed prior to surgery, and the location can be determined at the AV node if a rate of 45 to 55 with a narrow complex junctional escape rhythm, or below the node rate of 30 to 40 with a wide ventricular escape rhythm. Now we have a 70-year-old male presenting to pre-op clinic for total hip replacement. History of type 2 diabetes, smoker and obesity. Exercise tolerance is limited by arthritis and has no history of syncope. Please interpret this ECG. Pause now for your own answer. In this patient, I'm looking for signs of ischemic heart disease as high risk. The most obvious abnormality is an irregular heart rate. The PR interval is prolonging beat to beat with a dropped beat, which is Wickenbach phenomenon. So it's a second degree heart block Mobitz type 1. So for this patient, I would take an in-depth history looking for symptoms, a cardiology consultation, but likely no pacemaker as he's asymptomatic. Would you like me to look at the ECG in more detail? A reminder of the difference between Mobitz 1 and Mobitz 2 second degree heart blocks. Mobitz 1 has gradually prolonging PR interval with drop beats. Mobitz 2 has a fixed PR interval with drop beats after a fixed number of P waves. The clinical difference is that Mobitz 2 is much more high risk for progressing to complete heart block and usually requires a pacemaker pre-surgery, where Mobitz type 1 only requires one if symptomatic. 2-to-1 AV block could be either and is usually actually type 1, but cardiology consultation is advised. Anesthetic approach to heart blocks is fairly simple. If complete heart block, Mobitz type 2 second degree or symptomatic heart block, pacemaker or transvenous wire is usually required before surgery. If high risk block, consider pacemaker or transvenous wire pre-surgery, normalizing electrolytes and reducing vagal stimulation where possible. Early detection with ECG plus or minus outline and drugs and pacing capacity prepared. The management is very similar for all heart blocks. Consider the structure of prevention, reducing intraoperative causes, early detection and preparation for when it occurs for any cardiac arrhythmia. For references, I've used Life in the Fast Lane ECG library, which is an excellent source for simple explanations. ECG Wave Maven is an excellent source as it has hundreds of ECGs with cardiology level interpretations. This is great for practice pre-Viva and comparing your answers, but don't expect to get everything they do. The 2013 Anaesthesia Tutorial of the Week on perioperative dysrhythmias
gives a great explanation of the anaesthetic considerations in heart blocks and other dysrhythmias. Thanks for listening. Please leave comments for feedback and what topics you would like to see for the future, and don't forget to subscribe. Good luck with the bite.